Hello, and welcome to another exciting episode of Critical Care Transport Academy, Neurologic Emergencies. I'm Frank Byrd, and I'll be your host for today's lesson on the stroke mimics. We'll be looking at a case study that highlights the importance of recognizing stroke mimics and why the history and physical exam are so very important to improving outcomes for our medical patients. We won't have time to do a deep dive into all the many stroke mimics, but we will highlight a few important things to watch out for in the patient presenting with stroke-like symptoms. Hopefully this episode will be fast, so let's get started. Ready or not, here's an interesting case study to get the neurons firing. You're dispatched to a scene call at the corner of Easy Street and I Love My Job Avenue for a gentleman in his mid-50s with altered mental status. But wait, there's more. You've heard this exact dispatch information before, many times before in fact. At this specific street corner lives a homeless man that you know well. He's a very pleasant, homeless veteran that you have transported numerous times. You know that his medical history consists of alcoholism and hypertension, neither of which are currently being treated. This patient frequently reports having seizure-like activity, but he has never been diagnosed with a seizure disorder. Things are different this time, though. He is demonstrating uncontrolled tonic motion, and he doesn't stop the seizure activity like he normally does when you ask him to. He appears to be having a generalized seizure, so you draw up the midazolam, but the seizing stops prior to administration. You're hooking the patient up to the monitor and establishing an IV when your patient begins to come out of his postictal state. You notice that he's slurring his words. Concerned, you do a quick neurological exam and find that the patient has complete left-sided hemiparesis. You even confirm this with a Hoover test. What could be going on? Let's get into why considering stroke mimics is important. Strokes are a truly devastating emergency that modern medical care can provide a great morbidity and mortality benefit to. We all know that time is brain, and we definitely respect this fact. How good are we, though, at diagnosing stroke? Well, some studies suggest that almost half of patients presenting with stroke-like symptoms are misdiagnosed as stroke when they are actually suffering a mimic. Now, I'm not saying that we must be experts at differentiating, and no one gets it right 100% of the time, not even their neurologists. What I am saying is that we all strive to provide the best care possible to our patients, and learning more about some common mimics is an area for improvement. I think we should study and consider non-stroke causes on the differential for stroke for two broad reasons. The first is do no harm. We all know that TPA administration carries risks, especially when the patient doesn't need it in the first place. Treating someone for stroke unnecessarily can be dangerous at worst, and at best is just a misuse of precious limited resources. Second, not appropriately treating the mimics for what they are means that we aren't providing our patients the care that they deserve. We can potentially provide life-saving care to our patients with a stroke mimic if we can accurately discover and diagnose the etiology of their neurologic deficits. As we all know, it's important that the patients requiring specialty care get that care, and a mimic may need different care than what the center you brought them to can provide. Now that we're getting more interested in searching for these stroke mimics, what are our tools and techniques to do so? Well, as critical care transport clinicians, being expert investigators is often something that we shine at, and this is critical to our success. Obtaining important information about the patient's history can often mean the difference between timely treatment and a missed opportunity. It's important to remember that we are often the only source of patient history for other clinicians, and the information that you gather, or fail to gather, can have tremendous impact on the care of our patients. With all that in mind, let's get into 5 mimics to think about or ask about when a patient presents with stroke-like symptoms. I have a quick mnemonic that you can utilize to remember what we'll cover here today, and it's MPTSD. The first cause is metabolic. Probably the most widely known and searched for mimic is hypo and hyperglycemia, which are well known to have neurologic sequelae. While we're pretty good at checking the glucose, remember that the other required ingredient for aerobic metabolism is oxygen. So hypoxemia can also cause these deficits. Although rare, there are even case studies of CO poisoning causing this phenomenon. Some of these metabolic causes, such as hypoglycemia, are very important to catch because we can provide life-saving interventions to these patients in the field. The P is for palsies. Another common mimic of stroke is Bell's palsy. Bell's palsy is a palsy of the facial nerve which can present with acute weakness or total paralysis of the facial muscles, innervated by our friend cranial nerve number 7. Rarely it can affect both sides of the face, but typically causes hemiparesis of the face, mimicking stroke. While the exact pathophysiology isn't entirely understood, it's commonly associated with viral infections and a progressive neurologic deficit over the course of hours to days. Reaching into our toolbox, be sure to get a good history and ask about recent infections or immunizations that could be a causative agent. A key differentiating factor is that the upper face and forehead are always affected by Bell's palsy, less commonly affected so by stroke. So motor function of the eyelids and forehead can be a key indicator that a stroke is actually present, while the inability to move the upper face indicates a peripheral cause like Bell's palsy. Importantly, only the face will be affected in Bell's palsy, which does not cause many of the other effects of stroke, such as confusion or weakness elsewhere in the body. Another mononeuropathy, termed Saturday night palsy, from compression of the radial nerve, causes motor and sensory deficits of the arm, which can also appear stroke-like. This is a patient population in which we can potentially prevent iatrogenic injury, as they do not require TPA. Reassurance and encouragement are better medications for these patients. T is for toxological. We all know that intoxication can cause us to slur our words a little, but there are many other toxins that also do this and can easily be confused with stroke. There are a few interesting case studies, specifically with patients with ethylene glycol toxicity receiving TPA prior to their blood gas analysis, demonstrating a severe wide-gap acidosis. And while there are laboratory studies that can help confirm what toxins are in someone's system, we can again save precious minutes and potentially provide immediate life-saving treatment to patients if we can discover a toxicological cause of stroke-like symptoms. So again, what you discover at the scene may mean the difference between saving a life and finding out too late that this was a mimic. If you can find the causative agent, you can get these patients the definitive care that they need. An early consultation with the Poison Control Center and medical toxicology can significantly decrease morbidity and mortality in these patients. The S is seizure-related. One of the most common stroke mimics are seizures, and especially Todd's paralysis. Todd's paralysis, or Todd Paresis, is a syndrome that results in weakness or paralysis post-seizure, and it is thought to be present after about 13% of all seizures. This is very similar in appearance to a stroke, but searching for a history of epilepsy or other seizure will prepare you to treat the patient appropriately. And last but not least is diving related. This last one may seem quite rare, especially if you don't live near any water, but let's talk quickly about diving-related neurologic deficits. Diving-related neurological deficits can be life-threatening if untreated, and they require a facility with hyperbaric capabilities to treat. So while this pathophysiology may be a low percentage of your patient population, the mantra of time is brain still applies. A diving-related illness such as an arterial gas embolism causes brain death in a very similar way that a thrombus would, but TPA doesn't resolve this issue. Gas bubbles in the cerebral vasculature require treatment at a specialty center with hyperbaric capabilities. While gas bubbles do show up on imaging studies, Knowing the history and immediately taking these patients to the appropriate center could save a life that it otherwise might have been too late for. Don't forget to give these patients lots of oxygen as well. So, what happened with our patient in the case study? Well, he certainly could have been having a stroke due to his history of uncontrolled hypertension, but thankfully did not have a brain bleed or ischemic stroke. He also was not intoxicated, which actually was the problem. He was ultimately suffering from alcohol withdrawal seizures and also had Todd's paralysis. Thanks for listening.